So what have people told us about serious illness and what they want? And this was a group of people who were in facility care. Some had cancer, some had renal disease, some had other chronic illness. So obviously they want to be comfortable. I shouldn't say obviously, because not everybody does. Importantly, avoid inappropriate prolongation of the dying process. And most people can get this, right? That if it's their time to go, don't make it a long, drawn-out process. Achieve a sense of control, and control is a very individual thing. So for some people, it may be to understand absolutely every kind of medication that they have, et cetera, et cetera. For some people, it may be just understanding what's going on, and that's how they have a sense of control. Relieve burdens on families is a big issue for people. And strengthen relationships with loved ones. So it's interesting that people still desire to live and grow, even as they are dying. What do the family caregivers want? Well, this was a study done 1 to 2 years after the loved one had died. But I'd like you to look at the fact that, of course, they want their loved ones' wishes honored, and inclusion and so on. But look at the practical stuff: support and assistance at home, practical help, personal care needs, like all these things that that often have fallen off the table for what we offer at times, what we offer for people in the community. And what we may not have enough of. But also importantly, honest information. 24/7 access, like what to do in the middle of the night, to be listened to, privacy, and to be remembered and contacted after the death. And this is something that we're really finding out that is really important for people afterwards. So along comes palliative care, and we won't go into the whole history of palliative care. That in itself is interesting, but it really came up to support people at the end of life with cancer at first. And essentially it was for those with a terminal illness who were actively dying. It was controlling symptoms, treating the whole person, supporting the family, and supporting the survivors afterwards. However, palliative care has changed. And this is the World Health Organization definition of palliative care. And you can see it's a lot more complicated than it was originally. So palliative care is an approach. So it's not a place, it's not a particular medication, etc., which improves the quality of life of patients and families facing the problems associated with life-threatening illness through the prevention and relief of suffering by early identification, impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So palliative care today is an approach, but it's also backed up by medical evidence, and I'm going to show you a little bit of that. We're not only wanting to control symptoms, did you notice the word prevention? We're actually wanting to relieve suffering through the prevention of certain symptoms that we know can occur. And prevention of suffering can also be trying to educate loved ones up front about what's going to happen, what the natural course of the illness is. Because as you know, a lot of suffering comes from what people don't know and the surprise, because much of suffering could be expected versus what actually happens, and that gap can lead to a lot of suffering. Treating the whole person, body, mind, and spirit, identifying early the people who need access to palliative care therapies, and opening it up now to anyone who has a life-threatening illness. So any time in the illness, people can access palliative care. As always, supporting the family and supporting survivors. And many people get confused about what is the difference between palliative care versus end-of-life care versus terminal care. And our Providence Healthcare team developed a sort of palliative care egg. You can tell there's a lot of women, I guess we see things in a sort of eggish way. That palliative care is the large thing that encompasses and can be accessed any time. End-of-life care is really more when you're beginning to see signposts that this person has an advanced disease. And terminal care is really just care in last hours to days. So I hope that might simplify it, because it is challenging with a lot of different terminology. So I want to show you some data from the US when they looked at the timing of referrals to hospice and palliative care. And they asked people, well, first of all, they looked at their data and they found that people tended a length of stay in a hospice. In the US, hospice is a program, but you know, they have remarkably similar data to our hospice place data. In other words, we use hospice as a place where people go for end-of-life care. And they found, though, that many of the people arrived 1 week or less, or they got involved in hospice palliative care 1 week before their death. And certainly we experienced that too. They also found that it was quite a while before people got a palliative care consultation when they were in hospital for an advanced illness. And what they found is that when they asked a huge group of people, 237 bereaved family members, asked about the timing of the referral, and 13.7 reported it too late. And those who felt it was too late had lower satisfaction, more unmet needs, lower confidence, and more concerns about coordination. And I've certainly met many, many people who said, oh, I wish we'd seen you 6 months ago. Now, they might have been singing a different tune 6 months ago. They might have said, no, I don't want, so I'm not making any comment on that. I'm just saying sometimes it's easier to see your life backwards than forwards. The key piece of information that I want to present to you today is a really interesting study, and there are others, but this is the first that was really hit people's, it was a well-done study, of course a randomized controlled trial published in a good journal which doctors will read, put it that way. But anyways, New England Journal of Medicine, 151 patients newly diagnosed with metastatic lung cancer. And people agreed to be randomized to either early palliative care versus usual care. And they looked at the outcomes, length of life, quality of life, and their mood. They had the same access to chemo, and in fact, when they looked at it after, the people who had early palliative care also had same amount of chemo. The early palliative care group had better quality of life, and there, as you know, there are rating and scales for quality of life, and fewer depressive symptoms. Interestingly, they lived 2.7 months longer than the people who had usual care. Now, I told you they had the same amount of chemo, right? So, and this 2.7 months, you might say, well, 2.7 months, you know, that's not much longer. This is better than a lot of the chemo that they are offered with lung cancer. Okay, this is a better outcome. And this really surprised people. It didn't surprise the palliative care people, because we've often seen people who really get feeling better, you control their symptoms, they sleep better, they eat better, they come to an understanding of what's happening, and they actually live surprisingly long time. So this was a very good outcome, and I believe they also showed that the same group, the people with palliative care, had fewer burdensome interventions at the end of life. So when do you start palliative care, particularly with people with dementia? Because oftentimes, I think it must be incredibly difficult when everyone who comes to your facility, so to speak, is already circling the drain. I mean, that's why they're there, because they are not functioning very well. and they are nearing the end of their life. So how do you spot who, who should get palliative care? Well, I would sort of say, why not just make it part of your practice, and that you just integrate some of the things about from palliative care that you think would help you in your approach to people with dementia. And that you begin to sort of practice it as just part of dementia care. That didn't turn out. What it says at the top is application of the palliative care model to residential care. And what I'm saying is that rather than wait till you know the person is obviously dying, when they come to residential care, think about starting a palliative approach to care then. And you might say, well, please define what is a palliative approach. And it is a bit challenging. I don't know how that got into yellow, but it's a symptom-based approach to care. So, for instance, you'd be more concerned about how people are feeling their quality of life is than how much they ate for lunch or dinner. You might also think about, does it make sense to keep checking people's blood sugar values, particularly when we now know that you need to live another 8 years to benefit from rigid blood sugar control. So those kind of things. So your outcomes are based on the resolution of symptoms rather than what's their hemoglobin A1C and what's their creatinine, right? And really trying to understand from patient and family when they move in, what are their life goals? And care for body, mind, spirit, recognizing that people still want to solidify relationships, want to pay attention to both the mind and the spirit. The yellow there is improved quality of living. And importantly, preparing the decision makers for the future decisions that need to be made. So explaining to them what the natural history of this illness is. And I think we need to do better at communicating to families about the daily events that they notice, which is trouble swallowing, poor appetite, urinary tract infection, shortness of breath. If we connect those with the natural history of this disease and the progression of this disease, in other words, by saying, their infection comes from the dementia, the lack of appetite is natural in advanced illness. I also think, as an aside, we feed people too much in residential care. And then we say they only ate 50% of their meal. So I really wonder if that's the same, because we feed a little tiny person the same as we feed a big person, and then we say the little person only ate 50% of her meal, and the family's going, oh my God. Do you know what I mean? And I'm sure most of you probably try and take that into account, but sometimes I think we're worrying too much about the numbers. So if we communicate, the other thing I think we need to communicate to families is the natural process of dying. So what we would expect in the final weeks and days and hours. And people feel much better. It's often their first experience with this. And so they like to know what is normal. And really, I'd love to see that people don't come to residential care and we have to start the discussion about goals of care and things like that. It would be great if that had already started with their family physician, in the community, in acute care, and finally in residential care, so that they haven't come to residential care by default. In other words, well, we didn't want to go to hospice because blah, 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 so we came here. When in fact you may recognize that this person has a short time to live. I also think that maybe our family conferences, rather than talking about how the person is now, should maybe focus on how the person will be in the future. And preparing the family for what lies ahead. And sometimes I think family are perfectly willing to accept uncertainty too. And I think if we lay out a number of possibilities, that can be very helpful. And talking about the kind of decisions that will have to be made in the future, so that hopefully, and maybe even decisions can be made so that they're not made you know, on the telephone with mother, you know, like, well, you know, she's got a urinary tract infection and now she's drowsy and unresponsive, and, you know, not a good time to be decision making. So I'll just finish. This is an old quote, but I think it's very true. The lifespan of any civilization could be measured by the respect and care that's given to its elder citizens, and those society which treat the elderly with contempt have the seeds of their own destruction within them. So I think we all recognize that. That's why we're here, is to give people dignity and good care right throughout their life. So thank you very much for your attention.